Now I would like to invite Dr. Lakshmi for her talk on follow-up after cataract surgery.
So, thank you Laila Madam and KSOS for the opportunity. So, when we do a pediatric cataract surgery, with a successful surgery, the journey has just begun. So, the post-operative follow-up actually starts from the pre-operative period when you have to do a good counseling to the parents of the child when a pediatric cataract surgery is being planned. The immediate post-operative period, we need a smooth recovery from the general anesthesia, which has already been described. Post-operative examination may need to include newer techniques like flying baby technique on the slit lamp, or usage of a handheld slit lamp or smartphone cameras to see the anterior segment the next post-operative day. So the post-operative inflammation can be reduced to a large extent by giving subconjunctival injections, and pain management in complicated cataracts could be helped by using a depot injection or a subtenance anesthesia at the end of the surgery. Hourly topical prednisolone and homatropin to relieve the ciliary spasm and inflammation would really help in pediatric cataracts. The most challenging part is children with multiple disabilities and very small children being operated for cataract. It's very difficult to protect the eye from trauma and injury, and in the picture we can see immobilizer with which the child can even play. At the same time, the eye is being protected. The instructions to the parents should include a demonstration of how the eye drops should be instilled in the child's eye. Trauma should be prevented at all costs. Parent education is first and the last word in pediatric cataract. Follow-up regimen, we usually use a corticosteroid antibiotic therapy tapered over 4 to 6 weeks. Homatropin and atropine may be used in cases with aphakia or traumatic cataract, or in children with gross inflammation. Early visual rehabilitation is the key to success in a pediatric cataract patient. Aphakics, we need to give them glasses, ideally at discharge. Pseudophakics, the refractive error correction depending upon what the target refraction is, need to be given. Near vision aid should be given in children who are older than 2 years of age. Vision therapy rehabilitation should be continued in children who have multiple disabilities. The frequency of refraction and adequate correction should be explained to the parents and done adequately. Contact lens is an option in aphakics. Extended wear or silicone elastomer lenses, hydrogel lenses is an option provided the parents are properly educated and hygiene standards are maintained. The glasses, while prescribing for aphakic children, should have silicone nose pads for comfort. Aspheric lenses with lenticular design would reduce the magnification, the aberration and the weight of the glasses, and hooks on the ear can prevent the eyeglasses from falling out. So this has already been described. The target refraction need to be corrected in the post-operative period to get a good outcome. Amblyopia therapy and amblyopia therapy, that is the key to success in pediatric cataract, especially so in the unilateral cataract. The immediate post-operative period should be the time at which this should be started, and this should be counseled pre-operatively. Occlusion still remains the mainstay and continued parent education is needed. Handling post-operative complications. Post-operative uveitis is the inflammation is quite more in children, and this needs to be tackled with adequate steroids and intraoperative depot injections, because a post-operative uveitis which is not well managed would lead to a visual axis opacification and later on amblyopia. Vitreous wig, as already has been mentioned, could be a problem and may need surgical intervention. It could lead to even decentration or infections. Visual axis opacification can be found out only by a proper follow-up of these patients, and membranectomy need to be done in these children timely so that amblyopia is prevented and occlusion therapy need to be continued. Glaucoma can be picked up in a regular follow-up examination under anesthesia if necessary. Using a tonopin or a Perkins tonometer could help, and higher risk in surgery with less than 4 weeks of age. Glaucoma should be suspected in these children and followed up. Suspect glaucoma if there are changes in axial length, Hab striae, cupping, or myopia is quite alarmingly progressing. So timely detection and appropriate management would prevent glaucoma from stealing their sight. Capsular phimosis is another complication which need to be managed with either a surgical or a laser intervention. Secondary IOL implantation ideally should be done in school-going age, especially so in children who have poor compliance to aphakic glasses. Visually, other disabilities, children having other disabilities, maybe secondary IOL implantation may have to be done earlier. Post-cataract surgery myopic shift, last but not the least, it is something to be tackled, and later on they might require an IOL exchange or a refractive surgery to tackle that. Children with multiple disabilities, we often see these children, so they need to be put on rehab soon after their cataract is done. Correction of aphakia should be done, and adequate refractive error correction, post-operative complication management would help them. So on a recap, counseling for post-operative follow-up should be done in the pre-operative period itself. Prompt refractive correction, amblyopia therapy, and follow-up of vision to monitor for complications and timely intervention is of utmost importance in pediatric cataract surgery patients. So to end with, I'll just show this child who was operated on for a congenital rubella cataract with an IOL implantation, 1.5 years. So the first video shows the child with a vague visual behavior, and he is not able to even identify his father from a close distance. And the second half of the video shows the child after a successful IOL surgery, pseudophakia, and glasses in which he is able to look at his food and eat by himself. So this is the visual behavior change we can see in children. So a good cataract surgery and its follow-up is most important in a pediatric cataract surgery. Thank you.
Thank you, Dr. Lakshmi, for that very important topic. Follow-up is very important after cataract surgery in a child.